Welcome to Canada's most irreverent talk show. This is the Andrew Lawton Show, brought to you by True North.
Hello and welcome to another edition of the Andrew Lawton Show here on True North. It is Friday, August 18th, and as you know by now, on the Friday show, we like to rip up the usual format and do a deep dive into a big picture issue. Now, this is a big picture issue, but it's also one that on the ground has very significant implications for community safety, for public health, and as a result, it's been very heavily politicized. We've seen in the course of the drug crisis in Canada, massive increases in just one metric alone, the number of opioid deaths per year. Now, I live in Ontario, and I can say that for years, we all used to look at the drug problem as being a British Columbia thing. You'd look out and say, oh, well, all those things they're doing in Vancouver are not affecting our city. And very quickly, my own city of London, Ontario became one of the hotbeds of this drug and addiction crisis. And now we're seeing there really isn't a community in Canada that is immune to this. And there have been all sorts of proposals that have been pushed forward under the auspices of harm reduction, the most contentious of which I'd say is so-called safe supply, which is predicated on this belief that the dangers in the drug supply are among the most pressing threats to drug users. So if we can eliminate that variable, we can make drug use somewhat safer. Now, is this working? Well, there have been a lot of very conflicting perspectives on this and perspectives that have shifted. Just this week, for example, there was, now this is not a safe supply issue, but there was a story about a clinic in Toronto, in Leslieville, that had to apologize after they were giving out free chocolate in exchange for needles, which obviously the parents of children in that area weren't exactly too keen on. So there are a lot of different threads to pull on this issue. So we may go in some different directions here, but I have a tremendous panel of guests that have all done a great deal of work on this, either in the clinical setting, the research setting, or in the media setting, and in some cases in all three forums. So we'll bring into this show Adam Zivo, who is a columnist with the National Post and wrote a tremendous piece back in May that really delved into this issue from a lot of different angles. Dr. Julian Somers, who is a clinical psychologist and addiction specialist and a health sciences professor at Simon Fraser University, and Dr. Sharon Koivu, who is an addiction medicine consultant actually in my neck of the woods in London, Ontario, with London Health Sciences Center. All three of you, it's wonderful to talk to you. Thank you for joining me today. Let me start with you, Dr. Koivu, because I know you've actually evolved yourself on this issue quite a bit, and you've not come at this because of any political reason. You've just done what I think researchers are supposed to do, which is followed the science and have found that safe supply isn't really what you once thought it was.
Yes, thank you. Certainly, my involvement in this is working with inpatients at a hospital in London and in St. Thomas. And I guess originally, when I started working, the drug of choice in London was hydromorphcontin. And through working with patients, I was able to identify that hydromorphcontin was leading to an outbreak or an epidemic in our area, essentially, of heart valve infections, particularly the first valve in the heart called the tricuspid valve. We also, because of this particular drug, hydromorphcontin, had an outbreak of HIV. So when safe supply first started in our area, it was actually not in a response to fentanyl. We did have some fentanyl problems. When we had a fentanyl overdose in London, it was most likely related to using diverted patches or using the fentanyl patches. But safe supply started to help street-level workers, street-level sex workers get off of hydromorphcontin and onto something that we believed would be safer, which was immediate release hydromorphone, referred to as Dilaudid. So it's the same drug. This wasn't a treatment for fentanyl. This was specifically to get people off of hydromorphcontin. I was one of the people that thought it sounded like a good idea. It sounded like a good idea on paper because of the problems we were having in London at the time. But once it was in place, I started seeing other problems. So yes, HIV, we no longer have the outbreak of HIV. We were able to get on top of that for many reasons with a community effort. and our endocarditis rates have improved. But what I started seeing clinically was an increase in other infections. So since this started in London, we have had an increase in essentially all other infections that are related to injection drug use. The ones that particularly alarmed me was I started seeing an increase in spine infections. So an increase in what we call epidural abscesses, which for some people can cause horrific pain, horrific suffering, and often leads to paraplegia or quadriplegia. And currently, I've been working with a patient who's quadriplegic and a patient who's paraplegic, and one that we're hoping will be able to walk, but related to injecting. And just like when I was seeing people with the heart valve infections, I spent a lot of time asking patients what they were taking. And really, the common thread for almost all patients that I was seeing with this increase in infection was using Dilaudid, often either from the Safe Supply program or diverted from it. And I think it's, now people often will say, well, it's from the fentanyl. At the time when I started seeing these infections, we still did not have a problem with fentanyl in London. We do now, and we can talk about how I think it's related to the increase in opioids in London. But at the time, it wasn't. The two main drugs were crystal methamphetamine and Dilaudid. And the common thread I found was the Dilaudid. It led to other problems too that we, with diversion, making it cheaper, making it more accessible. But I think those were the first things that really got me to start being aware and critical. And I took that information back to the community, and was kind of surprised that it wasn't kind of welcomed as a place we needed to start doing research.
Well, and this was obviously a story that is somewhat familiar to you, Dr. Somers. I know you did something very similar. You followed the science, you looked at the effects of this, and you had quite a bit of pushback for conclusions you drew as well that were very similar, and that Safe Supply was not, in fact, safer.
Yeah, thanks, Andrew. And I'm fascinating listening to Dr. Koivu's remarks, because in a very specific way, they are actually, it's an identical experience in that, as we listened, Dr. Koivu's initial support was restricted, or was focused, I should say, perhaps, on a specific client or patient population, a particular context in which a substitution program could result in better engaging sex workers at very high risk in a variety of ways, and then seeing the unintended consequences of the implementation of that service in other patient groups or other segments of society. And these risks are not only the acute risks that Dr. Koivu and other clinicians see in their practices, but also longer term risks that they might also see, but that become more apparent when we group people together and look at the entire population. So it's well known that long-term administration, self-administration of opioids results in chronic risks as well as acute level risks. And so there are a variety of ways in which this approach poses risks. It also, I think more fundamentally, mischaracterizes how we would best address harms associated with substance use, including addiction in the population. It has nothing to do with a focus on supply. That's the approach of the war on drugs, is to focus on supply. And we've learned in these last 60 years that doesn't result in much measurable improvement in our local populations. It's important, but it doesn't result in much measurable improvement. Where all of the research has backed opportunities for progress is on demand reduction. Focus on the conditions that put people at high risk where resorting to addictions that put them and others at great risk, is a preferred approach to coping. There are ways of helping people, but it involves focusing on those very demand drivers. And we've been lied to, I think, by leaders, some deliberately, some innocently, and we've opened floodgates for profit interests to enter into the field. And that takes it well away from a focus on particular patient groups, high-risk sex workers and others, and seeks where's the biggest bottom line return. Now, we see companies now formally seeking investors in order to back an expected expansion of so-called safer supply in Canada initially, and then internationally. I'm simply summarizing from their promotional materials to investors. And Adam knows more about this than me. Some of what I've learned has been through his reporting. But the backlash was severe. Unlike anything I've encountered previously in my career, Adam's also covered that. Thanks, Adam. Bringing to light that the backlash is really a big part of the story here. Under what circumstances do scientists who have no evidence to support what they're advocating for jump aggressively on someone who's raising, in our case, myself and my co-authors, reasonable grounds for concern? How much is this program going to cost per year? And importantly, there are several concerns, but what's the exit strategy? If we succeed in engaging disaffected, disenfranchised people, remember, Safe Supply is not a treatment program. It's framed as a way of engaging people who are alienated from care. Great. Once we engage them in care, what are our next steps? And there are none. And there's a flat refusal to talk about it. And it sounds perhaps cynical to say this, but I believe there's a deliberate refusal because the entire profit motive hinges on perpetuating people's suffering so they remain good customers.
You've touched on, I think, an important aspect of this, which is the motivation. And I wanted to bring you in on this, Adam, because I do feel there's been a fair bit of mission creep on harm reduction itself. I remember originally when we were talking about Insight in BC many years ago, and there were obviously some concerns about that. A lot of the argument for just supervised injection sites, not providing supply, which at the time I think would have been seen as insane. But the arguments in favor of it were that, okay, we bring people into a space where we can then give them the resources to get clean and get off drugs. There was always that, whether it was honest or not, there always seemed to be this idea that if we bring people into the system, so to speak, we can work with them and help them get off drugs. With Safe Supply, I don't hear those arguments anymore. And maybe I've missed something, but it actually, to me, strikes me as though they're giving up on that idea of trying to fight addiction. And I don't know if that's an accurate read on my part, Adam. Like, what is the stated purpose of this program?
Well, I mean, we have to keep in mind that there are different stakeholders who have different motivations. So there's one part of this camp which is ideologically motivated by this idea that drug use is a right, that you can use drugs safely, that harms associated with drug use come from the criminalization of these drugs, not from the drugs themselves. And for these people, they don't think it's a problem if someone is chronically using opioids. They think that's perfectly fine. And so for them, they're not profit motivated. They're just very ideological. And they espouse this kind of strange strain of libertarianism that prioritizes the individual liberty of the drug user above all else, including community good, right? And so we see that now where we aren't allowed to criticize people for being addicted to, various drugs and harming others because that's imposing on their right to use drugs euphorically. Now, there's another group of stakeholders who seem to be more profit-oriented. And as Julian mentioned, there are definitely companies that are looking to make quite a bit of money off of this. So one thing that I became aware of earlier in the year was the existence of a new company known as the Safer Supply Streaming Corporation, which is currently seeking investors so that it can capture the entire value chain of Safer Supply. Basically, the people who are leading this program are people who have had a history of monetizing on psychedelics and cannabis. So they're looking at this in a sort of recreational lens, not like an addiction treatment lens. And I think that's really concerning. I think it's concerning that for-profit actors are coming into this space with no real background in addiction medicine and seem to be conceptualizing opioids and cocaine as like one big party. Now, you have these two poles, and you also have people who are a little bit in the middle. And one example here would be, let's say, Perry Kendall, who was the former public health officer in BC. So in his capacity as public health officer, he declared the opioid epidemic to be a public health crisis, which then allowed for changes in the policy environment in BC to allow for the approval of therapeutic use of heroin and the importation of heroin without getting, seeking approval from the federal government. After he advocated for all of these changes, he then went on to create a for-profit company known as Fair Price Pharma, which, coincidentally specialized in importing and producing heroin. And then he received a contract with the federal government to do just that, which is very questionable. I mean, there seems to be a very strong conflict of interest here. Now, from my conversations with other people who are involved in this space, it seems like he is genuinely concerned about the well-being of people who are in addiction. But at the same time, one has to wonder, how pure can his motives be if he's starting a for-profit company? As another example, you have Dr. Evan Wood, who founded the BCCSU, the British Columbia Centre on Substance Use, which is very influential in the addiction policy space. And when he was running that organization, they accepted dollars, they accepted funding from cannabis companies, and then produced low-quality research which suggested that cannabis would be an adequate response. Cannabis consumption would be an adequate response to opioid addiction. Research that completely contradicted higher quality studies being produced elsewhere in Canada. And then afterwards, he left the BCCSU and then accepted a high-paid position at a cannabis company, which I think should raise a lot of eyebrows here. So you see this habits of harm reduction leaders having very few scruples about accepting for-profit positions where they monetize off the consumption of drugs. And I think that any Canadian should be concerned about that.
Well, I know money is a very powerful force, and even in academia, money is tied to research grants, and sometimes there's no money in researching one thing, but there is in researching something else. But just to go back to the story you told about your own shift on this, Dr. Koivu, you were not, one of these evil, maniacal profit seekers when you thought this was in the best interest of patients. And looking around at your colleagues in medicine now that still very much believe in safe supply, which of those camps, to use the categories that Adam set out, do you think most of them fall in? Are they ideologues? Are they, profit seekers? Or are they people that, maybe they're not ideologues, but they genuinely believe that's where the science is leading?
I think that it's a tough question, Andrew, because just to really know someone's motive can be a bit tricky. I think that what I'm seeing, my perspective would be that a lot of the people in this area, for example, are ideologues, and that it's become something they believe in without sort of like believing in it so much that they're not seeing the downsides, sort of like seeing your child and not seeing the harm that they could do, that they don't want to see the harm. But having said that, the programs are receiving millions of dollars in funding. So even if that's not something that people take home with them, there can be lots of reasons to want to keep that kind of funding for your organization that isn't directly profit seeking. But with that $1 million, I think it's really important. I think it was $6 million for the program in London. None of that covers the cost of the drugs. So I'm not exactly sure what cost it covers, but it doesn't cover the cost of the drugs. That's covered by OHIP. That's covered by everybody else's, tax dollars. It's not. So any amount of funding from the federal government doesn't really cover the cost of the program. But that funding for an organization like a community health center is really important funding. So I don't know how much is motivated by a sort of desire to keep that kind of funding, even if that's in the context of a belief that that funding will help people and help the organization. So I think it's very complicated, but I also think it's really interesting how hard it's been to express any concerns about the program. I've never felt, I was a very quick adapter of being critical of Purdue. I gave talks before it was the thing to do. And every time I gave a talk, I would start by criticizing Purdue. And I remember being asked if I was worried about Purdue, and I wasn't. They never bullied me. I never felt unsafe to talk about it. But I have found that the environment has been very challenging to be able to say, this is what I'm seeing. I don't have a motive to say I'm seeing somebody who's quadriplegic and the suffering is horrific. The only motive I have is to end that suffering. So I don't have a personal gain from it. I have the horror of the trauma of witnessing suffering. And when I express that suffering, I've almost literally been told that those patients don't exist. And I feel like, tell that to those patients that I'm seeing suffering. I mean, I've been told that doesn't happen, they don't exist. I think the other thing that I want to make sure gets out there is that increasing more opioids has done nothing to decrease fentanyl, which is often illicit fentanyl, toxic fentanyl. So, and the goal that is now claimed is that it's to be a safer alternative to toxic fentanyl. That hasn't happened. It's increased fentanyl in London. It's increased overdose deaths in London. It's increased hospitalizations and ED visits in London. And looking at diversion hasn't been part of what the programs have done. But looking at specifically, just looking at the kind of goal of decreasing toxic fentanyl, once people become addicted to an opioid, to get the same effect, they either have to take more of it or something stronger. And what I'm seeing over and over again are people that have started with safe supply or started with diverted opioids that then progress to using fentanyl. So if anything, I'm finding that it has absolutely worsened the fentanyl crisis in our area.
Well, let's go ahead, Adam.
Yeah, I just want to make a point of clarification for listeners who aren't aware of why safer supply doesn't dissuade people from using fentanyl. So safer supply programs in Canada predominantly distribute hydromorphone, which is an opioid which is roughly as potent as heroin, if not more potent. And that's dangerous for someone who is opioid naive. However, fentanyl is at least 10 times stronger than that, which means that for a fentanyl user, that because of their high tolerance, hydromorphone doesn't actually do anything for them. At most, it manages their withdrawals, but it doesn't give them the euphoric high that they crave. So the actual premise of safer supply, that these drugs are an actual substitute for fentanyl, doesn't check out at all. And it's important to note, so I've interviewed at least 25 addiction experts across Canada at this point, most of whom said the exact same thing, that it's crazy to imagine that hydromorphone could substitute for fentanyl. The ones who haven't said that, they've only haven't said that because we haven't talked about that topic. But some might say, well, these are a few addiction physicians. What do they know? Well, it's important for us to remember that Health Canada itself is aware of this issue. In March of 2022, they published a preliminary report evaluating their pilot safer supply projects all across Canada. And one of their central findings was that even maximum doses of hydromorphone didn't generate a high in fentanyl users, leading people to go and sell it on the street to purchase more fentanyl. So Health Canada is aware that the central concept of their safer supply programs.
Let me ask you about that, Dr. Somers, because if there is such, unanimity among certain pockets of this addictions specialist community, as Adam said, why are people like you and Dr. Koivu seen as the dissidents here? I mean, where's the breakdown happening?
Well, it plays out over decades, unfortunately, Andrew. So there's a big gap in education. I've taught clinicians in medical schools and departments of clinical psychology, nurses, and the amount of time allocated to education on addiction is scant. So people finish, and there's a lot to learn, more and more, as clinicians. So we wind up with a big gap, and we have, it's a bit of an embarrassment that we're producing clinicians who reflexively draw a comparison between untreated addiction and diabetes. There's no one in the clinical literature who has decided through a force of frustration and will to quit diabetes, right? No one. But people do that all the time with addiction. And we need to learn from that in order to mobilize the factors that contribute to not only their motivation. It's not limited to that. It's about the conditions in which their motivation can be increased and actually expressed. That's what can give people the opportunity for wellness. Most people overcome addictions There are more ex-smokers, at least in higher income countries, there are more ex-smokers alive than current smokers. And the same has been known for heroin, cocaine, alcohol for decades. We don't teach the skills that mobilize clinicians' capacity and relationships to advance that. And so we wind up with this kind of, well, what do you do? What do you do? And because nothing has changed in neighborhoods like the downtown east side of where I live and in others, clinicians have gone there and seen, well, this is like nothing changes here. That's not because the people are incapable of change. And that's one of my biggest frustrations is we've had the opportunity in Canada. At Home Chez Soi was a multi-site several randomized controlled trials that aimed to investigate if people deemed the hardest to house in different regions of the country could in fact experience wellness. The answer is a resounding yes. With crime reduction, with reductions in medical emergencies, improvements in quality of life, and social reintegration. We started that work in 2008. Portugal had already shown the possibility at the population level because their whole plan revolves around social reintegration. That's a core construct in their national strategy, the 2000 national strategy, social reintegration. Now, having committed to that goal and realizing all of the improvements that they did over the next decade, it's important to note they did it without a single drug consumption site. The harm that's addressed by consumption sites includes not having safe places to live, being on the street and exposed to predation and violence. If one is committed to addressing those harms by providing people with safe places to live, you don't need consumption sites. So it's not a matter of are you for harm reduction or against harm reduction? It's about how should we best reduce the harms that are associated with drug use in our population. Portugal remains, I think, a real important test or learning opportunity for us, a natural experiment. They built on the experiences in Switzerland and England before in previous decades. So there is a volume of evidence that hangs together both from other countries and experimentally in Canada that we're turning our backs on. And the result is people who are not aware of that literature making decisions. And as Adam said, often with good intentions. We also have this weird dynamic where, look, addictions are diagnosed as mental disorders. At their core, they involve an agonizing frustration around loss of control. It's the loss of one's own control to influence behavior that is resulting in harms to oneself and often to others as well. And that's a core dynamic in what we refer to as harmful addictions, and why they are so create such strong mental suffering. And so we have this weird dynamic where we're asking people who are likely experiencing addictions, a loss of control over behavior that causes harm to them, if they would like publicly funded drugs to be provided. Well, they have not had much reason to think that effective treatment is available, or that there are ways in which they can gain greater control. And so, of course, they say yes. Of course, that would be beneficial. That would be an improvement over what they're currently doing. But it's the wrong question. We should be asking them, would you like access to the same resources that restore control that have been available to physicians who experience addictions for decades, or airline pilots, or in BC, public servants? Because all of those groups, and wealthy people, because all of those groups have access to forms of addiction treatment that focus on the psychological and the social, and that preclude use of drugs, at least in the short term, and they are highly effective. If, on the other hand, you are poor in Canada, there is no way for you to get access to psychological and social supports addressing addiction, and all we provide are drugs. This is the practice of stigma. Any leader who says safe supply is about stigma reduction doesn't know the meaning of the word stigma, because it is the definition of responding differently to two groups in the population based on how they look. If you look like a doctor, if you look like a public servant, an airline pilot, a safety-sensitive employee, we want to take care of you. We want you to have control of your life back, and we will help you get there. If you're poor, here you go. And we need to eliminate that discrepancy. Stigma reduction is the right cause. It's the wrong execution.
No, that's a fascinating and quite upsetting analysis there. And when you talk about housing, one tweet that I wanted to bring up at some point in the show is that it illustrates that when you have one problem, it starts to skew your way of dealing with other problems. And this is a tweet from a Toronto community worker that I think is involved with some of these organizations that are in the harm reduction space. And she writes, "Meth is a smart way to stay awake and avoid assault or theft on the street or in a shelter." This is someone who is looking at meth, which has destroyed people's lives and done so much damage, and saying, well, this is actually a thing that will help you avoid being raped or assaulted or killed if you live in a shelter because you don't have a home. So it strikes me that the problem here is actually maybe we should make sure that either shelters are safer or that people have a safe place to be, and not use meth as a harm reduction tool. And again, I'm extrapolating a fair bit from one tweet here, but it's that these problems are, as you say, Dr. Somers, very interconnected here. And I just want to make a point that we've been talking about this, and nowhere in this discussion has there been anything unsympathetic to people with addiction. It's not looking at them. No one's saying we need to lock them up. And I think often in a political context, that's what people try to reduce this thing to, which is, you're either anti-addicts or you're pro-harm reduction, which is not at all the case here. We are out of time, but I just want to give the last word to you on this, Dr. Koivu, because when we are talking about the stigma issue here and the idea of treatment, is there a viable model that you've seen to get us where we need to go? Or are we still looking for that?
I think that there are viable models, and I think we need to look at an integrated approach that looks at all the aspects of care. We know wraparound services, primary care, healthcare are essential. Housing is an essential part of being able to get ahead and away from an addiction. And I totally agree. It needs to be a safe place, not just a safe way of making an unsafe place less dangerous in a very short term, promotes so much danger and so much risk. That sort of like double downing on, doing more bad onto bad, because adding meth onto crystal meth, which causes all sorts of other diseases, onto another thing that's dangerous. And then looking at other strategies, opioid agonist therapy, methadone and Suboxone, Sublocade are absolutely, I'm seeing huge amounts of improvement, life-changing improvement when people really get on an opioid agonist therapy program. Often now, because of the income associated with selling safe supply, diverting safe supply, that's less accessible. Because to give up safe supply, you're giving up primary care, wraparound services, and an income. We have to change that. That can't be where you get those services. We need to have an integrated approach. We need to have an accessible, rapid access, good integration. We need to look at what really happened in Portugal, not how people are translating the decriminalization to justify things that weren't Portugal's experience. We need to look at what Alberta's doing. We need to look at what really has been done in Switzerland, and recognize the harm that we're doing, and not be afraid to recognize the harm both to the individual involved that we're locking into an addiction, and the community, and really look at why are there so many more encampments in London, and why are just adding hubs, might be a short solution, but as long as we're creating an environment in which people want to be in the core, want to be near the diverted drugs, whether they were housed from another community and are coming into London to get the diverted drugs, we have to be looking at the source of the problems we're creating and stop the flood of that problem as we're creating an integrated approach.
Very well said. That was Dr. Sharon Koivu, also Dr. Julian Somers, and Adam Zivo, columnist with the National Post. And by the way, we talked about it on the show when it came out. I mentioned it at the beginning. The piece came out on May 9th. Drug fail. The Liberal government's safer supply is fueling a new opioid crisis. It was probably one of the most evocative and in-depth looks at this issue that I've seen. It features Drs. Somers and Koivu and a number of other experts. And you did a tremendous job on that, Adam. So thanks for writing that and for coming on today. And everyone, thank you so much. It was a pleasure.
Thank you so much.
That does it for us. My thanks again to Dr. Somers and Koivu and also to Adam Zivo for coming on the show. We will see you next week with more of The Andrew Lawton Show here on True North. Thank you, God bless, and good day to you all.
Thanks for listening to The Andrew Lawton Show. Support the program by donating to True North at www.tnc.news.